So you might have heard of something called Home First Phase 2, which is occurring in Leeds at the moment. No worries if you haven't. It's something which is being talked about really in collaboration with neighbourhood health. Again, it's probably a term that you've heard thrown around. You might be wondering about the ins and outs of it, some of which are still being worked out, I think. The LCP is a perfect platform and foundation for neighbourhood health models. You may have seen guidelines from the NHS 10-year plan as well. I guess the overall consensus is that there is going to be a lot more focus on care at home and care closer to home, closer within people's homes. And ultimately, all partners working in a more integrated way, regardless of who employs you, to meet the needs of the local population. And we've got so many really, really positive and strong examples of different organisations working together in local care partnerships to do exactly that. So whilst some of the terms that have been thrown around are a little bit new, there's actually some amazing foundations across the whole of the city where we're already working in a very much a neighbourhood health way of working, and there's lots that can be built on. Just to put a couple of things really, the outcomes that we're really trying to focus on are better outcomes and experience for families, better experience for staff as well, meds optimisation, continuity of care. Ultimately, this first phase of work, there is quite a big focus on working with the most complex individuals in the most deprived areas to help reduce unplanned care activity across the partnership. I've been in other meetings where unplanned care activity, a lot of people often think of going to hospital. However, what we've seen is that unplanned care activity is also multiple GP appointments, nurse appointments, social prescribing appointments as well. So a lot of that can be based in primary care as well. But also our third sector partners. I've been in a meeting as well this morning talking about waiting lists, and I was quite quick to point out that if somebody's placed on a waiting list, it doesn't stop them turning up at a third sector organisation every day to help handhold until they reach that appointment. So lots of different ways that we can consider unplanned care activity. We're also looking to reduce isolation, thanks, Eleanor, number of bed days, and ultimately improve the way that we use the Leeds pound and the money that we have to spend in Leeds. Great, if you can move on now. Thanks, Eleanor.
Thanks. Thank you, Rach.
Thanks, Sue. I'll pass over to Sue now. Thank you.
Yeah, thank you. Sue Wilkinson, I'm a Pathway Integration Manager in the Frailty team at the ICB, so hi. This slide really just sets out the target population for proactive care in Leeds. As you can see, it's just under 47,000 people, and that's 5% of the Leeds population. And then the Venn diagram is showing you some of the data insight work that's been going on about this group. So you can see it's largely made up of a block of people with 3 or more long-term conditions there. And there's 20,000 people living with moderate to severe frailty, and about 17,000 people are living with a mixture of those conditions. We know that 25% of those people live in IMD1, and 23% are working age. There's some of the data analysis that's been done, and an average age of 74 years old. And in terms of coding, what we know about is 7% of people have dementia. 12% have a registered carer, and 11% have declared themselves as carers. A little bit of insight around some of the people in this proactive cohort. And I think it's basically local and national evidence is telling us that if we work more proactively in a much more neighbourhood proactive approach with this group of people, they will experience better health outcomes and will get better value for the system and a much more effective use of our resources. Thank you, Helena. And we also know that this group of people use a disproportionate amount of health and care services due to their poorer health outcomes. And so, for example, that 47,000 reflect 5% of people in this proactive care cohort, and yet they account for 19% of outpatient appointments, They have a longer length of stay, so that'd be about 10 days rather than perhaps 4 days for the average population. In terms of primary care appointments, more likely to use around 15 primary care appointments a year, whereas the broader population, that will be about 4. In terms of other unplanned care, we have, there's 14% of A&E attendances as well. And about 80% would be in receipt of social care packages. So the trends are, as you'd expect, much starker for people living in areas of higher deprivation as well. We know that over the next 10 years or so, we're going to see a significant increase in those people over 65 living with a number of long-term conditions, 4 or more, and also expecting to see more people, significant increase in people over age 65. So I guess that does present us with somewhat of a burning platform in terms of if we carry on doing the same things, we are going to just see increasing, demand against our existing capacity. So we've got that really strong argument there, as well as our clinical experience that tells us the real importance of more targeted and proactive care, as well as that effective intermediate care, if we're really going to support people living with frailty and multiple long-term conditions and reduce that pressure on health and care services. But I guess more importantly, it's about improving those outcomes for people and the experience of care that people are having. Thank you, Helena. So in terms of the data that we've been looking at, that really is supporting a much more targeted approach, as we know, in our neighbourhoods. And what we're aiming to do, and that supports the national framework, is working with vulnerable groups of people at most risk of deterioration. We're aiming to delay deterioration for people, maintain a person's independence at home as far as possible, and reducing avoidable exacerbations and also breakdown of care arrangements. The 5 core components of the national framework, which people may be already aware of, they're listed here. And you can see that first component is identifying the target cohort for greatest impact. So who's at most at risk in the population? And that's really what we want to spend today talking about. What is that population locally and what might that look like for yourselves? The other 4 components are carrying out that holistic assessment, developing a personalised care and support plan, and delivering coordinated multi-professional interventions to meet people's needs, and importantly, that development of a clear plan for continuity and also agreed follow-ups of care. Now, in terms of numbers of people and data analysis, Helena's got some great data for us to take a look at. But in terms of, just before we get to that next slide, in Otley, that's about for 2 to 3%, which is the ambition of people we want to work with, that will be 24 to 36 people. And in the Eden population, that's about 32 to 48. If we're looking at working with people, say from October time in that 3rd quarter of this year in a much more proactive way. And there's just a link at the bottom there. People I'm sure will have come across that national framework for proactive care. This is the framework that underpins the proactive care elements of the primary care network DES. So I'm going to now hand you over to Rachel, and she's just going to look at an example of how one area has looked at developing a networked MDT. Thanks, Rachel.
Thanks, Sue. So this example is actually from colleagues over in Crossgates and Seacroft, where they've been doing some proactive work with a range of colleagues to help identify a small cohort of people at end of life with respiratory problems. And this is just an example of what that network team has ended up looking like. And you can see that there is a huge range of different people, whether those are clinicians, housing, hospital, ops managers, carers support, healthy minds practitioners, neighbourhood networks, linking leads. Yeah, a full range. But at the centre of that is care coordination. And again, some people might have quite a definite understanding of what a care coordinator role or what care coordinating is, and it's becoming quite apparent that that has different meanings to different people, and that it's actually a role that can be done, or an activity that can be done within several different roles as well. So as we said, this is just an example from Seacroft and Crossgates to show the breadth really of activity of partners that could be involved in a piece of work. When we talk about multidisciplinary teams or multidisciplinary team meetings as well, We don't necessarily mean that all these people have to be involved in all of that activity. That feels a little bit overwhelming of how do you bring all these people together? But what we really want to focus on is the relationships between these organisations and teams and functions really as well, to ensure that the right people can be brought into the conversation at the right time, depending on the patient and their individual needs. I think I'm passing back to you now, Sue, or maybe to Helena.
It's over to Helena, I think. Thank
yeah,
you,
it's me
Helena.
from here. So in terms of that 2 to 3% that Sue was talking about, so that's sort of around 30 people-ish, depending on the size of the population. There's sort of question for sort of how do you get there? How do you figure out who those people are going to be? So of that, we've taken that sort of 47,000 that was talked about earlier on in the presentation and split it down by PCN area and by a number of other sort of categories in order to start understanding kind of where those pockets of higher activity use are, what those trends look like, and start to kind of get you thinking about what might fit into your current provision, what you might already be thinking about, where like how you can layer your local knowledge over that data. So the purpose of this pack is to get you thinking about that. There are a number of different ways that we've cut it. There are a million other ways that you could potentially cut it, but this is supposed to be sort of giving you some sort of framework to start thinking about who these people really are. So once you've sort of had a chance to, we've talked through the pack today, had a bit of a discussion, more than welcome to take it away and have another think. Other PCNs that we've presented this to have made it very clear, very understandably, they want to have a longer period of time to really think about this data. There's a lot of numbers I'm about to throw at you. But once you've decided kind of what broad group of people within this 47,000 or your cut of the 47,000 you want to have a look at, there are a number of other tools that we can bring in to start answering some more in-depth questions and start kind of testing some hypotheses with the ultimate goal of being able to find 2 to 3% of those people for you to initially target. And we do have a re-identification process to follow at that point. So there are 3 populations that we split this into, and they're the ones that were on that initial Venn diagram slide. Again, these are a little bit arbitrary. Any way that you cut this population would be a little bit arbitrary because we know that people are incredibly complicated and everyone's an individual. But these are some broad groups that their behaviour is maybe a little bit different and their care provision might look a little bit different to start thinking about kind of where you want to focus. So I'm going to talk about population 1, and when I say that, I mean people with moderate or severe frailty. When I talk about population 3, I'm talking about people with at least 3 renal, metabolic, or circulatory conditions who are not moderate or severely frail. So those 2 groups don't overlap. And then that overlap population is population 2 in the middle. So those are your people who have both moderate or severe frailty and at least 3 of those renal, metabolic, or circulatory conditions. Those conditions, there's 9 of them, and there's an appendix to this slide deck that I'm happy to flip to if you're curious about which conditions those are. COPD is in there, heart failure is in there. You're talking about your quite severe conditions, and that's based on a piece of data analysis that was done a while ago with clinical support to identify which conditions drive that kind of multimorbidity. Because obviously there's a wide combination of conditions you could have, and some are more clinically acute than others. There's also reference to mental health in here, but none of these groups require you to have a mental health diagnosis. However, we know that mental health conditions are quite prevalent in these groups. So this is really more for your reference when you are able to look at it in your own time, just so you can kind of see, of that 47,000, this is what these cuts look like. So you can compare your data basically to the overall. So I'm not going to spend too much time on this slide, but it does give you a sense of kind of what this population looks like in a bit more detail. But the really interesting bit, I'm sure for you, is when we get down to the actual PCNs. So we've got Otley and Eden are separate on here. It would be possible to look them combined if that would be more helpful, but my understanding was that would probably be a bit more helpful to guiding your thinking. So like I said, there's a lot of numbers on here. So what I've tried to do is draw out the ones that might be the most interesting. And these are not, I should say, first of all, Otley is not significantly an outlier in any of these areas. These trends are replicated in the overall population, but there are a few differences. So the youngest population is that population 3, and it's also the smallest by quite a long way. You've only got 370 people in Otley who fit that 3+ long-term conditions without frailty or without moderate or severe frailty. Some of them might have mild frailty, and their average age is 73. The oldest is that population 2 with an average age of, let's call it 80 because it's 79.99. And you've got fairly high dementia prevalence across those two, population 1 and population 2, those two kind of more frail cohorts. 12% of people in population 1, so those people with moderate or severe frailty, have dementia. That drops to 9% of the people with both conditions. Your population is in all three a little bit older than the city average. For these three groups, and your highest rate of common mental health issues is in population 1. That's 34% have a recorded common mental health issue. That drops to 25% of that overlap cohort, and just 13% of that population 3. Although again, those rates are slightly lower than the overall 47,000 average. Your highest rate of GP activity and community is in population 2, but interestingly, your highest rate of unplanned bed days is in population 1, which is not necessarily the same across the city. That is a little bit different for Otley, and you have a much lower obesity rate in this population, although again, since you're talking about older people, the obesity rate might be slightly less relevant. So that's your Otley data, and then we switch to Yeadon, done the same thing. Common mental health issues slightly higher than Otley, but about the same as the citywide average. Largest population by far is population 1. That's the same for Otley. All populations are slightly larger in Yeadon. There's just more people. And a slightly younger population than Otley, but still slightly older than the whole of Leeds for that 47,000, with the same split of population 2 being the oldest and population 3 being the youngest. Similarly high rates of dementia, again, slightly lower than Otley, but still higher than Leeds. And for this population, the highest rates of activity are all in population 2, which is a bit more in keeping with the rest of the population. Still that lower obesity rate, and a very high rate of smoking in population 2, but again, similar to the city average for this population. So there are a lot of numbers on here. I drew out the ones that I thought the most interesting, but obviously there might be ones that speak more to you. The other thing just to note, and I haven't highlighted these on these slides because it's the same across the city in every single PCN and in the overall, but the gender split is quite distinct. So population 1 is significantly more female. It tends to be a ratio of about 2 to 1. That's the same in both Otley and Yeadon. And then that flips for population 3, with there being about twice as many men as there are women. And then population 2 balances out about evens. And that's the case across the board. Haven't figured out why that is. I'm sure there's clinicians on the call who have some opinions about that, but that's just something else that I wanted to point out. So in terms of areas of focus, we're sort of hoping that PCNs will be able to pick one of those 3 populations, although again, there's flexibility in that. So just want to sort of give you a sense of kind of where you might focus if you picked one of those. So that population 1 is the largest population, and you can sort of have a focus on that, sort of aging and dying well. They've got the highest rate of common mental health diagnoses and dementia, particularly in Yeadon for that common mental health. And so you could be focusing on supporting advanced care planning and avoiding escalation to emergency care. If you were to focus on population 2, you could be focusing on that admission avoidance and keeping people at home because they have a slightly higher A&E attendance rate, and in Yeadon have the highest number of unplanned bed days, although again not the same in Otley. They're the oldest population across both. They have a similar unplanned activity usage, and in Otley have a higher community utilisation. Because of that combination of conditions, they do have probably the highest clinical acuity and need overall. So you could be focusing people out of hospital and improving care at home. I should say that the difference between population 1 and 2 tends to be quite narrow. So there's probably some overlap there, but just to kind of try and draw out a bit of a distinction. And then if you were to focus on population 3, that's the youngest and the smallest population with the lowest activity rate. So you could be focusing on prevention and early intervention to prevent that escalation into frailty and into one of those into population 2. Comparatively high recorded alcohol abuse and smoking rates, particularly in Otley. And so you could be focusing on that prevention of deconditioning and trying to keep people well for as long as possible. those are just some sort of more narrative options. Again, there's a million other ways that you could cut this, but just to sort of get you thinking, really. And then I think am I handing back to you, Sue? I'm handing back to Rachel.
Yeah, I think Rachel's going to be picking this bit up. I think this literally we just want people to time to raise some questions, and really we're just teeing up some questions here, Rachel, aren't we? A bit of food for thought.
Yeah, thank you. So obviously there has been a lot of information there. Thank you so much to Helena and her team for pulling that together. I guess it's your opportunity to ask questions to Helena to pull that data apart a little bit. That would definitely not be my forte. So does anybody have any immediate reflections? Lovely, Fleur kicking us off. Thank you so much. Do you want to come in?
Yeah, thank you. Thanks for the slides as well. I'm sure speaking just for myself, I did have a look at these when they were sent through. Just on a quick question, are we able to see this population for our own patients? Are there any searches on System 1 that are set up so we can have a look at? So for me, we're only a small practice, so I suspect we would have quite a decent handle on the type of patients that who they are, and be able to give a bit more reflection on if that's the appropriate group that Airborough's patients need to be looked at. I know we're looking at a PCN footing, but I think that would be helpful if that's possible at all. Thank you.
So as far as I'm aware, we haven't had a conversation about actually setting up System 1 searches. The re-identification process that we've been talking about has been pulling from the Leeds data model and then re-identifying through our data partner. However, this data can be cut to a practice level. So we could do similar cuts from the same dashboard at a practice level if that would be more helpful. Yeah, but we don't have searches set up in System 1 at this moment.
Yeah, thanks, Fleur. I think because we've got this brilliant support from the BI team and all this data analysis, they've been able to move along that identification of people through the Leeds data model. Really, much improved process, really, with all the governance that you might need. So this was felt to be the preferential way to proceed, and I think that's amazing that you can get this list back. So there is a process for that, Helena. I'm not quite sure if that's the follow-up conversation or if you can comment on that a bit, or we'd get others to come and talk to the team about that.
I would not be the person actually running that process, but there is another screen on this same dashboard that I've pulled these screenshots from that gives you a list of pseudo patient IDs. And my understanding is we'd narrow it down to that list, send that through to Next, and then they would be able to send the re-identified information directly to the practices. So it's I think it's quite a slick process. And should also say that this data is accurate as of March 2025. So it's as up to date as it can be, but obviously not quite as up to date as a search in System 1 would be. There's trade-offs.
Thanks. Do we have any more questions at all? Or is anybody starting to possibly consider what population might be right for the PCN or the wider LCP, or maybe which cohort is not right? Is there one that's standing out that you're thinking, no, that's probably not one for us? Is that Nicola and Dave? A duo today?
Yeah, we're sharing one screen, doing a bit of the environment. Hi, I'm Dave Kendall, CD and GP in Otley. Thank you for that presentation. Thanks for the slides beforehand, which was really useful because there's a lot to get through and it's nice to have a think beforehand, as Fleur sort of said. I think going forward, that'd just be an ask, really. Could we just get data in advance just so we can make most use of these big meetings? So I guess this is going to sound adjutant. It's not meant to, so please don't take it this way. But I suppose what I'm thinking here is, what's the direction of travel here? So all of this is absolutely laudable. It's great. We're looking at a targeted population. We're understanding our patients a bit better. We've got some data behind it, which often drives good decisions. But where are we going with this? So you've said we could look at 2 to 3% of our population, which feels like a reasonable group. We're not talking about looking at 20% of this group, etc. So straight away, that feels like it's a doable thing. The expectations are low to start looking at that, which is reassuring. But I guess, where are we going with this is my question. So, this is going to involve some time from all partners in this room to look at these sort of populations and to change the way they're working, potentially focus quite a lot of resource on a very small number of people for all the right reasons, for all the right reasons. But where is that resource, time and shift coming from, and what are our outcome measures? So if we're saying we'd like to look at 2%, do we have to do that? As in, is there something down the line which says, well, you achieved only 1.5%, etc. So I suppose it's just more about, can we understand what the overarching kind of route of direction of travel, because there's been a huge amount of stuff flying around the last couple of 3 weeks because of the 10-year plan, and just a sense of what that looks like. If that's not too broad a question, just where does this fit in terms of a roadmap? Thank you.
Yeah, thanks, Dave. I think you've summarised that extremely well there in terms of the points and what we're trying to achieve. So in terms of a guide, I guess, is the primary care network framework around proactive care, which I hope you've had opportunity to see. We've brought that discussion along to the GP Assembly, and that's our aim there is to provide some structure and support. Sorry, I've got a cat helping me here. Some structure and support to practices and primary care colleagues as they're implementing that national proactive care framework. And you're right, it's set out as that 2 to 3%. We want this to be achievable. And that's within 25-26, that's this year. And we're setting out those outcomes and what we're hoping to achieve in that time. And we'd want that to be bespoke to yourselves, because clearly we need to identify the population and then work that up with you. So the aim is that we would be proactively working with that group of people from sort of October, November time onwards through to the end of the financial year. But we're very much seeing this as a multi-year programme, as you say. This is a shift in thinking, and it's seen as a driver towards neighbourhood health. So how do we change the way that we're working so that we release and free up some time for that more proactive care? So that's our plan going forward, to support those aims around neighbourhood health within the 10-year plan. So yes, it's starting small and then building on those successes, and also trying to support people in terms of, we often meet challenges and barriers along the way. So it gives us some time to try to support practices and unpack some of that with yourselves. It's part of the bigger programme around Home First. So there's work going on alongside around improving our awareness and prevention of things like falls, and how we can improve that resistance for people and reduce deconditioning for people around falls and frailty, for example. There's work going on around intermediate care, improving discharge from hospitals as well, and all under that Home First programme. There's also an interesting piece of work going on with Leeds City Council, which is a prevention diagnostic. And we're going to hear a little bit more about that, but that's work looking at how can we identify people earlier and perhaps in more improved ways, in terms of, we've got things like large language models these days, haven't we? And I'm certainly not the best person to talk to that, but we're perhaps moving away in the future from things like clinical searches into things that are much more effective for teams, really, in order to identify people earlier. So I don't think there's a quick answer to releasing those resources, Dave, but it's about how we work together. And one of those ways of doing that is part of that local care partnership, and bringing in partners and talking to providers and partners about, well, what's your contribution to this conversation? And the network, that slide that showed the networked MDT, that was the work in Crossgates, and it's around the team around advanced respiratory, which is a cohort that you can also focus on if that fits your population. So that's not about having lots of resources and lots of people tied down to a virtual room or a room with 4 walls. It can be about, well, I know who to contact. We can have the conversation. We don't need to have a case management meeting that runs over 2 hours. Yeah. So it's about how do we use our resources more effectively, really. And I think we'll answer some of those questions as we go along. And I think the backdrop to Leeds is we do have that great support in our local care partnerships. And I think that gives us quite a lot of firm ground that perhaps other areas don't have. So I hope that goes some way towards answering that question. And this is about identifying the cohort to begin that work. So let's work practically, really, and then begin to solve some of those issues that you've talked about, Dave, if that makes sense.
Thank you. So thank you for that. So I guess I like tangible things. I can put my hat on a bit. So, for instance, setting aside an hour to come on a meeting, it's just tangible. I can get my head around it and know what I'm talking about. So, and I guess everybody's got their own sort of things as well. So I suppose we need to have a conversation as our PCN. You need to have a conversation as their PCN to sort of think about what might fit our styles of working and our immediate populations. You know, you've offered 3 populations there. And we might even have disagreements with our PCN, which form we go for. So, you know, that takes a bit of time. So in terms of next steps then, so I suppose, you know, the next step, we've got a lot of people in the room today, and that's great, but I'd wonder whether we all need to be in the next steps, etc. So, but, you know, what are the next steps, and what would you see as the next time scale to have the next sort of, this is what we thought about, this is what we're moving forward with?
I think we'd want to get together reasonably quickly with that, wouldn't we, Rachel? And just to sort of add as well, what we're working to build at the moment is some ways of capturing outcomes for patients and people's experience using System 1 and EMIS to capture that. People might have come across a questionnaire called EQ5D. That's being piloted in some areas at the moment. That'll be offered. That looks at quality of life for people before and after being working in this proactive way. We want to look at impact on staff. We'll be measuring things like unplanned care and impact on primary care appointments and so on. And we also want to capture some patient stories as well. So we'll be building that in terms of evaluation so we can learn from that going forward. But in terms of more practically, Rachel, when are you hoping to get people together to begin to move forward on this?
I think, so one of the roles in our team is to try and work out everybody's availability, and Abs has done a great job getting so many people here today who want to be part of the conversation. So it's a lovely turnout to have from a wide range of organisations as well. We'd be looking around towards the end of August to have another follow-up conversation around this, to try and pinpoint things a bit more when people have had time to dig into the data. It's impressive data, but it's quite mind-blowing as well, knowing which bits to pull apart a little bit further. So yeah, we're looking around, I think, the 3-week mark. Fleur, do you want to come in?
Thank you. Yeah, I was just thinking, we've got a lot of support for severely frail, that we've been looking at that cohort for such a long time now. So it feels for me, just off from this meeting and the slides, that moderate frail really feels more, because we really need to be working towards preventing patients moving into severely frail if we can. I mean, obviously you get severely frail as you get older, but if we can try and support patients for longer before they have to move into that group, because really this really is all about improving overall well-being, isn't it, for patients? So it isn't just the physical element, it's all the other things that you've already raised, Sue and Rachel, on those slides. So as I say, for me, Fleur, it feels moderate, sensible to be looking at concentrating on moderately frail rather than the severe frail, but looking at maybe the ones that are sort of midway in on the frailty index, on the moderately frail index. So we're trying to keep them there rather than tipping in. That's my little observation. Whether that's proved right with data, I don't know, but thank you.
I think what you said there, Fleur, is really important. And so we've done 4 or 5 of these sessions, maybe with other LCPs as well. And there's been similar conversations and ways of thinking, like, do we focus on what we've got a foundation for already and enhance it? Do we build on existing MDETs that we've got, but make sure that we're really bringing in wider partners like housing, third sector, some more non-clinical partners as well? Or have we got something that works really well already within? So therefore, should we look at a different cohort and put a bit more time and energy to prevent them becoming that cohort? And I guess those are the conversations that would be really helpful if they happen behind the scenes for us when we come back together. Hayley?
Yeah, just to comment for Yeed and PCN, I think we need to spend a bit of time looking at our data, but I'd also echo what Fleur said. You know, we spent a lot of time working with our severely frail and still do, and I think there is opportunity to still build on that, but without speaking to my colleagues and without knowing, you know, what they want to look at, the moderately frail maybe slightly more appealing. But yeah, we just need a bit of time to look at that data. I'm just concerned about the time frame and still being in school holidays. I don't know what other people's diaries look like too. I don't know if early September is a bit more realistic, but obviously we'll try and work around what we can.
Absolutely, Hayley. we know that this piece of work has arrived at speed and is happening, it's continuing to happen at speed. And so at the moment, we're just going with who's available and where we can get going. And even if some people haven't been able to make it today, we're having conversations outside of the call as well, to help advance things. We can aim for August. Like you say, it might not happen, especially with the bank holiday at the end of August. It's often a popular time for holidays, isn't it? And then getting the kids back to school is stressful enough. So yeah, we'll definitely do our best to make it as easy as possible for everybody. Have we got any more questions at all? Lovely. Nicola, Dave?
Sorry, I'm a monkey for filling gaps when there's silence. It would be great to hear from other people, because I recognise that so far it's been sort of GPs and GP practices talking, and this mustn't be about us, essentially. But I suppose one query was, to help our thinking, it might be useful we had some national examples. You know, this has been tried in various models before, various names, various themes and models of care. So, you know, we've been offered 3 different populations, but there might be one barn door that, even though it might not be what we think is the right population, there's good evidence that is the right population to look at. So have you got anything that would help us with that? Because we, you know, Fleur's described one population, I've thought about a different population, but there might be the third population might be exactly the one we go for because there's evidence that that's the bang for buck. Have you got anything that would help us with that?
Thanks again, Dave. The British Geriatric Society have set out a number of documents that are hugely supportive of the work in terms of collating national and evidence from a number of studies across the country, and also a roadmap for how you might deliver proactive care. And that's pretty much what's informing the approach that we're taking. Of course, in terms of multiple long-term conditions, there's some further streams of work which we can tap into, colleagues with Dave Edison and the long-term conditions population group, so I can talk to Dave a little bit about that. But I think the first port of call is like those BGS documents which I can forward to you, and as part of preparing for this work, we've looked at a range of other studies up and down the country, actually, so I can forward you those if you're interested as well. That's helpful.
Thank you. Yeah, I think just the more the merrier. You know, we have a gut feeling, but sometimes gut feelings are the wrong direction, so that'd be helpful. Thank you.
Yeah, indeed. The other interesting thing is we've also been accepted as West Yorkshire ICB as part of a national frailty collaborative. So waiting to hear what that looks like, but it'll be providing us some support, things around you know, peer support, and generally the sort of things that you're talking about, what evidence is there, and sharing that approach and how things are going, but also some support around evaluation as well. And then there's a further piece of work around nationally, a submission around working with the rising risk, you know, people with long-term conditions. So that's actually being looked at the moment, but there's another national potential expression of interest we might be part of. Sorry, Emma.
No, that's fine. I just felt I wanted to come in from a Leeds community healthcare point, and it's nothing to bring anything specific to the table other than just to let you know where we are at the moment in the trust and some conversations that we're having and some workshops around proactive care. This is why I invited Jane Paragic in, because me and Jane are actively involved in some workshops, quite a lot of intense workshops at looking at our proactive patients and the care that we will, obviously what we will be delivering, and looking at a lot of early intervention and the step down visits when they've been on whole ward, etc., and how we manage them in within the long-term conditions. And I just wanted to sort of step in really to say that this is why we wanted to come to the meeting, and we brought quite a few people from around the Eden neighbourhood team and people that are involved in lots of discussions that happen a lot around proactive care, that we are similarly having quite a focus on that at the moment. It was just for some assurance that, you know, we are looking at this within our trust as well. I don't know if Jane wanted to come in and discuss any of the main, if there's any links, because we're not looking at probably directly at the population. Obviously that then figures, stats, etc., will be led very much by the geographics that's the findings, but we obviously are working very closely, and one of the key parts, which was mentioned right at the beginning, is building these relationships up and working how we work in conjunction together to try stop duplication and ensure that we've got a better streamline for the patient. So we are very aware that across the city, what has identified is that we have a huge variance per primary care, but it's about how we can then still tailor into each area to make sure, again, that we're not doing duplication, that we are working in conjunction and having that partnership working. And I think that's a big drive at the moment for the trust.
Thanks, Emma. That's really helpful to know about that, and hugely aligned, isn't it? And the big opportunity that we've got here, really. So it is about reducing that duplication, as you say, and be more effective for people and for the system.
Well, what we're looking at the moment as part of that planning is the workforce planning, because we've got advanced practitioners that are actively on course but due to complete. So that workforce plan is how and what we need to align to ensure that we've got the right workforce in the right place for the proactive work, because we seem to have it quite, I would say, nailed on as close as possible around our home ward section. That's been running for quite a couple of years now, but our proactive work is just started to ramp up now, and we are starting to look at what do we want that as a workforce in the trust, what do we need to meet the I suppose the figures really of patients, and how many people we need to, you know, what kind of caseloads and sizes are we looking at around the population. And yeah, it's just to assure us that that is from our end all being considered around what our offer looks like and what kind of numbers and caseload sizes we're looking at and what kind of workforce we're going to need to require to meet that criteria. Thank you.
Thanks, Emma. I'm just looking who else is on the call. Have we got, I don't want to pounce on you, Debbie, but I think you might be the only third sector organisation that we, I know Otley Action for Older People weren't able to make it today, so, but we're grateful that you could attend to represent AFSET today. Have you got any initial thoughts or anything?
I'm not sure on initial thought. Obviously, we're here to support kind of whatever we can, but very mindful that we are the only third sector one that's here. And I know we have got Otley, who's just as interested as we are in terms of being on side to help with whatever we can. I think for us, it's just the resources to do that. We have done lots of work with frailty before, with the LCP and with the council and lots of other places. So for us, it'd be nice to amalgamate that and kind of keep going with that. That being said, I think any of the populations that you've got would fit nicely with us, and we'd be able to help in some way. It just depends what that ask were and what the resources were on the back of it to be able to allow that to happen.
Thanks, Debbie. Some really important questions there. And apologies, Julie is here from Otley to represent them today. So thank you. Glad you could make it, Julie. So yeah, Debbie, I guess then I've just captured that for you. It's really understanding what the ask is of third sector colleagues within the room as well. It might be as well that a lot of the activities that are happening are already going on to support these patients, but it is just that more joined up way of working to ensure, I think as Emma from LCH pointed out, that we're not duplicating and that the journey is better for patients as well. Any more questions at all? No? I won't make Dave fill the silence again, don't worry. Thank you so much then, everybody. Huge thank you to Helena and Sue for pulling all that together and presenting it to us as well. Forgive me, I've just come back off annual leave. Next steps are those that we'll send the information out to everybody, Helena and Sue. for people to, well, the people have got the data already, haven't they? Lovely. We'll do a little summary of what we've captured today, and then we'll be in touch around next steps as well. Okay, thank you so much, everybody, for your time.
Thank you, Rachel. Thanks, everyone.
Thank you.
Thank you.